Hello, everybody. I'm so excited to be here today. It's Allie Wyatt. I feel like it's been a while. I'm the co-founder and CEO of Female Founder Collective, and this is part of a series for the 10th House, which is our private membership community. And actually, behind the scenes, we have been working very hard on creating a new 10th House experience. So we are reformatting the membership, and we've been trying to think a lot about the common threads of things that you guys have as pain points, and we have been cooking up something super exciting. So we'll be sharing that soon. And our next cohort is going to be fashion, accessories, and jewelry. So if you're in any of those businesses, and you might have an athleisure brand, you might have a socks business, you might have a wearable jewelry business. All of those are relevant for this cohort, but we are going to be introducing a whole new structure. And so stay tuned for that. But without further ado, I'm very excited to get into it with our guest today. I was just telling her backstage that I'm going through all the things that she is looking to solve for, and that she's already researching. So we couldn't be more thrilled to have Dr. Rhonda Voskuhl. She is the founder of CleopatraRX. She's a renowned neurologist, researcher, women's health advocate, menopause expert, and professor of neurology at UCLA, where she directs the university's multiple sclerosis program. Dr. Voskuhl is also advancing women's health through CleopatraRX, a company she founded that is pioneering hormone-based therapies to support women through the menopause brain fog. I think we all probably have some degree of brain fog. I'm definitely in the perimenopause phase of that. Her career bridges cutting-edge science and compassionate patient care, making her a leading voice in both neurology as well as women's health innovation. And in addition to discussing fundraising and scaling, today's session is also a way to amplify World Menopause Month. October is a designated World Menopause Month to raise awareness about menopause, its symptoms, and available support options. I'm so excited about this. So I'm going to get right into questions and ask you, what made you step away from research and academia and into entrepreneurship?
Well, actually, I didn't step away. I'm doing both. And I can tell you why I think it's important to continue to do both, because we can continue to make news as we get the word out of what we've done with the company. We continue to make news, and it gives us organic visibility, which is pretty cool. So my academic life is and was and still is to get NIH-funded grants and patents. So I'm an inventor on patents that are I work at UCLA, so they are UCLA patents, but they were licensed by CleopatraRX and this novel solution that we have for menopausal women. So the reason I decided to go really spending so much time founding the company, it's just so much work, founding a company and the whole thing was, I mean, it's a lot. It's a lot in addition to my other job as a professor. It's just like, wow, okay. But anyway, I love it. And the reason I did it, I'm putting so much time into it, really, is because I'm in the faculty neurologist for the UCLA Comprehensive Menopause Program. A bunch of GYNs, they send them to experts on heart, breast, bone, brain. So I'm the brain person. And so because I'm focused on the brain during menopause and how it's affected by loss of estrogens. So the reason I chose to really focus so much on the company was because it's really not fair to all the other women in the country who live in places they can't come to UCLA. They're not Beverly Hills, Bel Air. They can't come here. And to see me in the UCLA Comprehensive Menopause Program as the faculty neurologist, they have cognitive issues they're very worried about. They may live on farms. They may live in inner cities somewhere. They just can't get here. And so I said, it's just not right and it's not fair to keep this all to ourselves. And so what I did is created CleopatraRX, which, as you probably are kind of a little bit aware, I'll talk about it, but it's a telehealth medicine company. It's a prescription drug. We have a group now of doctors across the United States, licensed nurses licensed across the United States, a compounding pharmacy that is standardized and huge, one East Coast, one West Coast site, shipping directly to people's houses. So now they can get it with me at the UCLA Comprehensive Menopause Program at UCLA, or they can get it across the country. It's commercially available. So it's really exciting, although we made to take this to all women, not just a few.
So tell me where you saw the gap in the market. And obviously there's huge gap. There's a giant white space when it comes to menopause. I think that we're all discovering, right? And the more we discover, the more we see the holes. Can you talk about why you feel that Cleopatra specifically fills a certain hole?
Well, it definitely does. So menopause in general has been more or less not up to date with some of the treatments we have available in general for menopausal symptoms. And those that we have are focused on FDA approved for hot flashes and for just the perimenopausal area. But women will be without estrogen a third of their life. It's not
Right.
coming back. It's age 50 to 85. And so it's a long time. And estrogens are neuroprotective. They protect the brain. Loss of estrogens are bad for the brain. And so the brain has been completely ignored in the treatments we have. And it's important. Why is it important? Because 60 to 70% of women have brain fog. And specifically, that's a layman's term, but it's cognitive issues, verbal memory, working memory, concentration, processing speed. They have problems. And now they've reached a point in their life where they're at kind of the top. They've reached the CEOs, or they're the lawyers,
Yeah.
the doctors. They're these people that now they can't find the right word, or they lose a train of thought. And
Mhm.
it's a competitive world. And I think it's just a huge gap for society to have women who's all they need is a proper and safe hormone replacement therapy targeting the brain that's safe for the breast. And we can fix this, and it's not out there. I think it's not out there partly because women weren't running things and the men just didn't really understand it.
It's very true. Oh, and just the gap is growing and growing, but I'm very glad that you've started it. But I'm also interested in the fact that we are going to talk about fundraising. And you didn't actually start fundraising for Cleopatra until after years of foundational academic research, proof of concept, and patent filings. Can you share a little bit more of why you decided to wait and raise that seed capital?
We didn't need it. I've been NIH funder for 25 years. I have a large one,
Yeah.
7.2 million from the NIH, and it's on focusing on estrogen and the role on brain health in women. Women are more likely to get MS, Alzheimer's disease, even healthy women to get these cognitive issues. So this is a huge problem that the NIH has recognized, and I have funding for NIH. My trials have been funded by the NIH, and some of I've also had funding from nonprofits such as the Conrad Hilton Foundation. And Nancy Davis, who's a funder of MS, she's in fashion and jewelry, by the way. She's a big Hollywood kind of socialite person, and I've just had a lot of support from a lot of different sources. And I live in LA, and these
Yeah.
people are very interested in the things I'm doing that have implications for MS, Alzheimer's, and women's health, particularly the brain health. So I haven't really had to. And so we formed the company, and we did begin to raise money, just to do the startup activities that we had to do for that.
And can I ask you how were you able to fund those? So you said you already had funding from NIH and then I guess private investors. What did you have to show the NIH? Like what did that grant process perhaps
Oh
look like?
God, that's just horrifically difficult. Only 5 to 10% of grants get funded, and the one I have is so competitive. I've got one of 15 neuroscientists across the country. It's just incredibly difficult, but it's been a long road. That's what I do. I get NIH grants, and it's just incredibly. These are very large. They're 1 or 2 million, and the one I have now 7 million. So it's just the
Wow.
trials are anywhere from 2 million to 10 million each. So it's an incredibly rigorous process. Sometimes it can take 3 years to get the grants. Some people never get them. Again, 90% are not funded that are submitted to the NIH. They're thrown in the trash after reviews. So that's a whole process on how to get NIH grants that is completely different than what I'm learning with the company.
And did you have people around you that had already understood how to do those? Or is that because you had participated in other processes that had gone through an NIH funding grant process?
I mean, I did training at the NIH after my med school in neurology. I went to the NIH as a postdoctoral fellow, and I learned neuroimmunology. So I've always been involved with the NIH, and then I've submitted grants. I got my first one 2 years out of becoming an assistant professor at UCLA. During the first years, I got my first NIH grant, and they just continued. And then I also do reviews for the NIH. I review other people's grants. So I've been so enmeshed with the
Been
NIH
ingrained,
for
yeah.
25 years. It's just been part of my DNA at this point.
Got it. Got it. And then in terms of the lessons you learned in raising the first 300K of seed capital, like anything you can share with the founders that are listening that are going through the process themselves. Maybe they're in healthcare, maybe they're in tech, maybe they're in another industry, but would just love to hear some of the big takeaways that you have.
Right. So in raising the money that I raised for the company, I think what's been important is, and what it's just the mission. It's got to be big. People will provide money. They'll invest. We actually have a nonprofit arm too for women who can't afford it. And I mean, so I think people will see whether people have the expertise, whether they know what they're talking about. And I mean, I've just done this for a long time, so I kind of do. But there are also, you have to be addressing something that's, I think, a big question, a big gap. I think that's what gets money. I think when they see that there's a big gap and there's somebody who actually has the expertise to fill it, people get very excited about giving money. The thing I wasn't as used to be honest, if we want to talk about problems, I think I was used to writing grants that were very large amounts of money, and I would say exactly what I was going to do. And it's not like a small budget. It's many, many, many pages with sometimes many collaborators across the United States, 16 sites in a trial, for example. It's not a simple grant, but university sites. But the point was with raising money for Cleopatra, I found that they not only want to know what you're going to do with the money they invest today and how you're going to spend it. They want to know, like, what's the 5-year goal, the exit strategy, and how many years. I mean, this is like another world. There's no exit strategy on an NIH grant. You get the money, you do the work, you get papers, and you get more grants. You continue to progress that way. But the idea of the finances of it, I guess, were the thing that I had to bring other people on, and this, the idea of how we're going to really make money. I'm not used to making money. I'm used to bringing in money and spending it and accomplishing things, but I wasn't used to.
Did any of your backers ask you, Rhonda, to specifically bring on additional individuals to your team?
I knew that. I mean, and I knew that because when I would talk to people about investing, it's like, well, what's going to be, we needed a CFO, we needed a CEO who could raise money. And that was very clear to me. I'm not somebody who raises money to generate profits, if you know what I'm saying. That's not what I do. And I knew that from the very beginning. And so that's what we did.
And so how did you identify those people? And then what did they change about your process versus when you were raising money through grants, for example, through the NIH?
Well, it was really just, honestly, it was just word of mouth. It was just people that I knew that were interested in the kinds of things I was doing. And they happened to know somebody who was really good at raising money. They happened to just be at a gap in their job, or they happened to be interested in adding this on part-time to what they were doing. And they had a lot of experience in startups and how to expand. So that's how I got to know them. We just started talking about, I knew the mission, I knew the goal, I knew what needed to be done. I had ideas about how much it would cost, because things for nursing, pharmacies, I know that kind of cost a lot of that stuff before. So it was a change from what I'd done at UCLA through NIH grants, but I did it all along. I knew I had to work with those people because that's, what I didn't have was the finance.
So the first people that you hired, it was a CFO and a CEO?
Yeah.
Is that accurate?
Yeah.
And how did you, even if they had maybe the background that was right, how did you ensure that these people were going to be the right people to work with you day in and day out to create?
Honestly, well, the CFO has just been great from the very beginning, and we just got along great. The CEO, actually, we changed because the first CEO was the one that licensed the UCLA patents that I'm the inventor on. He licensed them, and he had a lot of other things going on, and I don't think he put enough emphasis. He wasn't a woman, and I don't think he really got it. It was just like another thing, if you know what I'm saying. But he did. He had a role that was very important. He did license the UCLA patents originally, and that's good because it put him into the whole sector of moving forward to the market. That was a good thing, and it worked for a while. But he also didn't have enough money. Honestly, he didn't have enough resources. We needed to scale it. We clearly needed more money put in, and so we changed CEOs, and now it's actually fantastic. Things are just really taking off. It's great.
And now what does your team look like, Rhonda? Do you have a big team, or is it just predominant? And how much of it is, under the grant, the initial sort of team and process that you were putting underneath the NIH grants versus the new?
So they're pretty separate. These are separate. The NIH grants are there so I can continue to do research and I can make them work. So last week I had a paper accepted in Science Translational Medicine. It went on the newswire for UCLA as well as Clover. My PR put it out, and it got over 400, almost 500 people picking it up. And
Wow.
that's how I get on Oprah. That's how I get on the Today Show. I basically still do research and I make news. And that brings visibility to me, which then takes people of Cleopatra to our site. So the NIH funding is really that mission to continue to do that, continue to do the research. So I don't just make comments about other people's research. I actually do research and I want them to comment about mine. I want to become an expert in the field, the person for the brain in menopause. That's what I am. I'm becoming, and that's because the research that I continue to do through the NIH grant funding. So the funding for the company is completely separate. They're not to be conflated together in any way because we are a public university. We don't put public money into private companies. That's not what we do. There's a firewall. And so the private company fundraising is completely separate.
Got it.
The team that we have today, you're asking about that. The mains, there's people, of course, a few at the top, and it continues to be, it's like an algorithm, like a tree, like everything always is. And so at the top, we have the CEO who's really fundraising, and he's also got a lot of success. Raised over $1 billion for fundraising in another industry. And he also has experience with some marketing. And then the CFO is the same one that I've had all along. And he starts that. And he also managed some of the legal. Now we're bringing in a legal team from Boston. It just keeps growing. We've got a nurse, an RN, who was really good at not just managing patients for 20 years, but she also did in telemedicine, which we really needed a telemedicine person. So this is me. I'm the founder. I'm the direction. I'm the mission and the vision of what it should be, as well as continue to generate all this publicity that I do and give advocacy talks and education. But those are the 4 people at the top, and then we have. The nurse has now got a nursing team, and she oversees, as well as the CFO, some of the financial aspects of it. Will oversee. We have a telemedicine doctor group that's licensed across the United States. Those doctors would be considered in that. We have a marketing team now that the CEO has marketing experience to overseas. We did hire a PR firm a few months ago. Lauren, who's on this call, is with the PR firm. We hired a social media people. It just keeps spinning out, right? To more and more.
And was that a team that your CEO put in place that he said, like, this is what we are going to need in order to sort of get to that next level?
No, I mean, it's just kind of developed organically what we needed, and we just take it off. We know now everything works. We've already treating over 300 patients across the United States. We've just got to scale up. So the next phase, we're scaling up. We're doing a VC round right now. It's going to be for $5 million to scale up from and increase the ARR. These are details about the ARR and the patients want to go from and to and how we're going to get there. And the CEO should probably give that talk. But it was just a matter of seeing what we can do and trying things and this was obviously we need this, we need that, and we raised money with family and friends, angel investors, to get to where we needed to be. And now we're at the point where we're going to a VC round.
Got it. And I want to talk a little bit about your model, because I think that is important as you sort of think about the proper fundraising for it. And that's, how did you decide you have a physician prescribed subscription-based direct-to-consumer model? How did you decide on that versus other business models?
Well, it had to be. The science is we need a better HRT. The HRTs that we're using are from the 1980s and 90s. They have concerns about breast cancer.
HRT, for everybody listening, is
it's menopausal hormone replacement therapy. It's the estradiol action of the Premarin. I mean, these are the things that have been around for 40, 50 years, and they have a lot of baggage and negative data because of breast cancer risk and clotting and cardiovascular risk. Some of them have been negated because they now do a transdermal with estradiol, but there's always going to be the worry about binding to that estrogen receptor in the breast. And so I came along as a neuroscientist and I said, well, estrogens are also really good for the brain, and we're never going to be able to treat for that long with this estradiol, because estradiol is used for hot flashes at the lowest dose possible for the shortest duration. And why? Because of breast cancer. You just can't expose the breast to that estrogen at a high dose for that long, because we know that from the 80s and 90s, okay? So I knew as a neuroscientist, a neurologist, that we're going to have to do something for no estrogen in the brain for a third of your life, 50 to 85. This is never going to work, the estradiol. And so I worked on looking for a different estrogen receptor in the brain, and I found it. It's a receptor that's not the same one as in the breast. It's unique to the brain, and it binds very weakly to the one in the breast. And so there you go. We've got one that can cause protection in the brain and not put the breast at such risk. It's just chemistry and it's neuroscience. And so I identified the receptor, the cell, et cetera, to help the brain. And it's a prescription drug. And the beauty of this thing too, though, is why it's taken off so fast, is because this treatment, it's a novel. Estrogen is a umbrella term. There's estradiol. Mine that we use is estriol. It had to be put with the right progesterone. It's all hormonal chemistry, in other words. And so, but the beauty of it is, for safety, this estrogen I'm using has been used in Europe and Asia for 40 years, and they know it's safe. And of course it's safe. It doesn't bind strongly to the receptor in the breast. That's why it's safe. I'm just now using that for the brain. And so it's a lot of really cool things that come together where you don't have to worry about safety anymore, because it's been done for 40 years. And you can go straight to efficacy, which is for the brain. And so it had to be this model. I mean, it's not a supplement. It's not something you can get without a prescription. It is an estrogen, but it's a different type of an estrogen than the estradiol patch. It's estriol and it's a pill. And we made a blister pack. We put it right to dose time with progesterone. So it's all optimized, a blister pack, not for birth control like we were used to in the old days, but a blister pack designed for menopause.
Very cool. So in terms of operational, talk to me again for a second about what are some of the biggest challenges that you've bumped up against as, you had your first round of seed funding. Now you guys are going out for your second round. Like, what are the big things that you are trying to solve for with that $5 million?
The biggest problem we have is how to reach people. Marketing, because we're basically this is basically, it's a direct to consumer. So they hear about us, they see about us, they go to the website, they take a brain fog quiz, they're screened for HRT contraindications, and they're prescribed. They go nurse, doctor, they get prescribed. It's shipped to their house. The blister packs are. How do we get them to know about us? How do we get them to know who is Cleopatra? How do we get up on the Google search list?
You have so much credibility, by the way.
We have a ton of credibility. That's not the problem. The problem is getting the word out, right? That's the problem. And so that's been the biggest challenge.
And so is it, in terms of your go-to-market strategy, for example, you aren't prescribed by independent physicians. You have your own team of physicians that prescribe it on a subscription.
Yeah, we have three. We actually, to the detail of it, we actually have 3 pillars. This is something we formulate as we've gone along. We have 3 pillars that are possible for prescribing. It's got to be a doctor who's got to prescribe, and it can be. I do it, and now there's another neurologist. We're adding more in the comprehensive menopause program. Now the GYNs at UCLA are comfortable with this different estrogen. They say, "Oh yeah, we know that's safe." I say, "Well, this is what we need." We see, they see tons of people over there now. And so the GYNs can prescribe it even without a neurologist, but some of them it's more complicated. They'll still send them to me. So that's basically the situation of a university who's got a comprehensive menopause program, and they don't ignore the brain because they shouldn't. And now we're looking at other universities to make a collaboration with them. I don't want to name them yet, but the idea would be there are menopause clinics actually coming up. Comprehensive menopause programs now are rising a lot. It's a very hot topic. And so my point is, we want to work with them and bring them neurology. We want to bring the brain, not just hot flashes, not just vaginal dryness, not just a cardiovascular disease, and not just bone, but also the brain. So we're approaching those menopause centers to bring a neurologist in all of those places, or they can identify one and we'll work with them and teach them how to do this. So that's doctors prescribing. And some doctors will hear about us too at meetings.
Right now it's direct to consumer, but you would eventually take it to other universities.
We're doing that too. Everything's in parallel. So we're now contacting other universities as we do the direct to consumer. So they're not mutually exclusive. And then we have other doctors who hear about us. They talk to me, and then they start prescribing. We've got several in different states now that are prescribing because they said, we've got this huge need. We don't know what to do. They hear about me one way or another. And I do a lot of talks and presentations. And so they'll contact me, and I kind of give them a mini training on how to do it. And then they basically feed them into our pharmacy network, ships to their house, back and forth. And then the third one is, as I said, direct to consumer. And that's where basically we have our own doctor network. If they can't find a doctor, or they don't have access to a doctor because of where they live, then we have our own doctors who they can go on the website and sign up and see one of our own doctors. So it's really 3 pillars.
That's fantastic. Well, there's a lot of influencers out there too that are leading the
That's
conversation.
part of the thing. Yeah, that's part of our outreach is influencers. Yeah.
Yeah.
We're interviewing them now. It's just there's so much to do to scale up.
Yeah. And just an aside, as a patient question that I have is obviously their patches is the format of that's actually delivery mechanism, or are they pills?
Pills. And I'll tell you why. So estradiol back in the Women's Health Initiative days of the 90s when I got all the bad publicity, one of the problems was not just breast cancer, was clotting. Estradiol, that's the one in the patch. Why is it given as a patch? It's given as a patch because when you take it, they used to take it orally, and when they did, it goes to the stomach, which goes to the liver, and the liver puts a group on it to create a new estrogen called estrone. And estrone, the metabolite, causes clotting. They figured the estradiol manufacturers figured that out, and they said, we can't give it orally anymore. We've got to give it a different way. And so they put their chemists to work on that to give something that they could give as a patch transdermally that's absorbed. It's not that easy. Creams are not very well absorbed. Your skin is a barrier by definition. Your skin's a barrier. Yeah. And so when you put creams on, it's got variable absorption to the blood. It's got to go to the blood if it's going to affect vaginal dryness or breast or bone or whatever it's got to do. It's got to get into the blood. You've got to absorb it. And so they couldn't go orally with estradiol. They had to use the patch, and they got a transdermal system, which is very good. It does go into blood, and then good things, it decreases hot flashes, and it's good for vaginal dryness. But is it good for breast? No. Is it good for brain? I don't know, because it's not been studied for brain. The one I'm using is estriol. It's been given as a pill for 40 years in Europe, and it still is. And the reason it can still be given orally is because when you take estriol orally, it goes to the stomach, and then the liver tries to put that group on it. It can't, because it's a different chemical conformation. You can't make that group to make the metabolite that causes clotting. So you don't have to give estriol as a patch. So we give estriol as a pill. That's why it fits into the blister pack. The pill is AM, PM, estriol, progesterone, the right type, dose, timing. It's a pill, not a patch.
And when you think about the impact to symptoms that women are having for menopause, does that pack specifically, does it target multiple symptoms, or is it specifically for brain health?
Multiple. So we already know from Europe that estriol has been used for hot flashes forever, for 40 years. We already know that. We already know it can help with vaginal dryness. I'm not so sure whether it's as strong to help bone or not. So if that's people's primary issue is osteoporosis, then they probably should go on estradiol patch. I don't know, or phosphate. They're a phosphate. They can do other things. But I don't know. I think it can help a little bit, but I don't know that it's that strong. But for ours, we basically do focus on brain, and part of our thing is we now have a paper. I've got a paper now pending. It's going to come out within weeks, and we've shown in our 12-month data that just like I had already done this, by the way, in MS patients for 10 years, and I had already done this work in women with multiple sclerosis who have a neurological disease. I had already shown that after 12 months of treatment, it improves cognition, it reduces atrophy in parts of the brain related to cognition, and it helped the blood biomarker for degeneration. I'd already done that in women with MS. So now all I'm doing is taking that to women that are healthy, that have cognitive issues of menopause. And what we're finding in our 12-month data already, and this is papers coming out soon, and that is that indeed, just like the MS patients, after 12 months of treatment, their cognitive symptoms are getting better. They basically they say that it's severe, moderate, mild, or none with respect to verbal memory, working memory, processing speed, train of thought, concentration. These are getting better in these women, statistically significantly better. Otherwise healthy women with brain fog symptoms, those specific cognitive domains, they get better. So that's what we're doing, and the results are coming in. And I predicted it. I think it's going to take time. What it does, it's not. I want to say one thing about what brain fog is in a little bit more detail to know why it works, and you're going to get there anyway with the questions. And so brain fog is also a layman's global term. What it actually is, it's not decreased IQ, it's not global functioning. What it is, it's not math, it's not orientation. What it is, it's very specific things. As I mentioned, verbal memory, processing speed, concentration. These are very specific, but they're important because they undermine women's confidence when they're trying to work. They're trying to keep track of a lot of things and do it quickly and do it smoothly, be in presentations and do it. Lawyers making cases in a court, etc. Now, it's more than just symptoms too. First of all, it's more than just hot flashes, because hot flashes, when you treat them, that's good, because it helps their sleep and they don't have night sweats and they have a good night's rest. But it's more than that, because these women, even when they don't have hot flashes, women will have cognitive symptoms. That's first of all.
Mm-hmm.
Sometimes they have hot flashes and those get better. Sure, their cognition is a little bit better the next day, but it doesn't help them in the long term. Women who've been menopausal for a long time and have not taken any hormone replacement therapy will have atrophy, not in the whole brain, but in certain parts of the brain associated with memory, processing speed. Lo and behold, it's the hippocampus is the name of the structure. It's just a detail, but they don't have global brain atrophy, just like they don't have global brain dysfunction. They have cognitive domain specific problems. They have regional brain problems. So what our drug was shown to do in MS is to fix the cognitive domain specific problems and to fix the regional atrophy. And so now we know, I identified the receptor in the brain that it works through to fix those problems.
It's incredible. It's so exciting that there is something that is out there that is helping these women.
It is.
People.
That's why we've gotten a lot of organic publicity from it. It's pretty cool.
Yeah, I was going to actually ask about the publicity to understand. We've heard from you that you are hiring a PR agency, or you have hired a PR agency. We've met them. They're here with us. But out of curiosity, were those of initial, and excuse me, I don't know why I'm just trying to focus. I'm curious how you landed those spots. Is that something where it was in partnership with your PR agency? Did you have people reach out to you? Like, how did you become such a credible and authenticated source of information? Obviously, there's the obvious one of your education, but I'm curious how you got those spots.
Because I have publications in very high impact journals. And the one last week was in Science Translational Medicine, and that's picked up on every wire, Reuters, AP, Yahoo News. They said this is a major breakthrough. That one is on an X gene effect in the brain. My next one's is estrogen in the brain. I've been doing this in MS, and now I'm doing it in Alzheimer's, and also helping menopausal women with cognitive issues. And so the news is the news, and people pick it up. And then when that happens, people like Oprah, I mean, I've met, she wants me on the show as a neurologist, and Maria Shriver is very interested in dementia and the brain. She's got the Women's Alzheimer's Initiative. The New York Times had a session on estrogen in the brain. So who are they going to ask to speak? It's going to be me and two other people that are doing basic science. One's at Cornell, one's at different couple of universities that are doing this. So, you just do these things. And that's why it's important for me to continue you see why I want to continue to do not only the company, I continue to do these things, and we continue to have papers, and it just feeds more and more news into the whole thing that can then be spun by a PR agency, which they are doing. So they were hired about 3 or 4 months ago, and now they're getting me, I'm becoming a commentator on, I mean, my goodness, a lot, women's health, all these magazines and news things. It's been organic initially, and now it's just spinning. And then the marketing goal is, how do you capture all that stuff to drive people to the website?
Well, so that's what I was going to ask about, is how have you pivoted from just being a voice and a source of really valuable information for these news outlets to actually helping to drive business results?
I just think, I've got help through the marketing team that we have, of course, the PR agency, the social media group that we hired, and they help get my message out. And I continue to do presentations and talks. And I was on ABC 7 News yesterday. It's going to come out on Tuesday in LA. So there's just continuing to do things, to get interviewed by news, and then you can ask them how they spin things out. It's kind of like not my thing. You know that I'm not a marketer.
You haven't changed like your talking points or anything like that?
Well, the only difference is I have to make it more in layman's terms.
Yeah.
There's a difference between, last week I was in Berlin talking to the Einstein Center for Neuroscience, and that's a bunch of neuroscientists, nerds like me. But, you obviously change your words a little bit when you're talking to those guys, or women too. You're talking about the specific cell in the brain. You're talking about the region of the brain. You're talking about a lot of things that are a lot of detail, or the sex chromosome, what chromosome is it, what gene is it? These are details, but they all get it, that it's important. And so I've had to really be able to adapt and change the terms I use for the audience, and then the course, the neuroscientists are not sophisticated at business or money or marketing. They know nothing about it. And so this is a different call for me because you guys have expertise that I don't have. And so it's been an exciting world. It's just a new world. And honest to God, to get ahead in this world, I say in my talks and I'm also a women's health advocate. I've been ahead of a very large organization to help women in science. It's a detail. But the point is, I've learned that it takes women in all stages, not just physicians, not just neuroscientists, but it takes politicians, journalists, these advocates, and stars. I mean, Halle Berry's talking about it, Oprah's talking about it, Naomi Watts. I've talked to all of them about it, and Maria. And so, when you have all these women come together from these different aspects of life, that's the way to get things done. You won't get it done with just that or just that or just that. We've got to embrace what other people do and come together with a common cause. That's how we're going to beat this thing. That's how we're going to win. And we are winning because we've got so many women at this level that's really cool. They're over 50 and they're very successful and they care about this. So hopefully our daughters they'll be treated way ahead of time. They don't have to worry about what are we doing. These drugs are 50 years old and they don't address our brain. So, it's going to happen and it's really cool. I just think it's a matter of timing. Timing is so good. Women are finally at this level where we're helping address women's issues.
No, it's so exciting. I mean, it's why we're here doing what we're doing is that I think women are sort of taking the mic and women are also taking the reins and saying, I'm going to actually start solving for these problems that I have in the world. Like it doesn't need to be status quo, that we just continue on and live and endure the problems that are being thrown our way. I mean, it's pretty crazy that we've had to deal with it for as long as we have.
Yeah, they just said, they're getting old, they're having hot flashes. It's like, some things you can't do anything about with aging, but you can replace some hormones if you can do it safely and you can benefit some things. We don't have to endure it. So, I just think it's important. And I think women were afraid to talk about it. They don't want to be seen as old or not sexy. And Halle Berry says, well, I've got it. So then that solves that problem for us. She's obviously sexy. And then you've got people that are, these other, like Maria's brilliant. And so you've got these women that we're not ashamed to talk about it if they're going to talk about it, right?
Yeah. No, absolutely.
Too. I mean, you've got all these women that are so good at what they do, and if they're willing to talk about it, because before I think they're worried about being looked down on.
Now, question for you, because obviously, like you said, you have these big name people that are talking about it and are in the conversation with you and are reaching out to you to get in conversation with you about it as an expert. How are you utilizing those people to help grow your business? Or are you? Like, have you formalized any way, and is your marketing org working at all to figure out a sort of process for working with those individuals?
I think we should probably do it. I haven't pushed them to that degree. I know them. It's a relationship, and I'm kind of working on it. I don't want to use them. We have a common mission to educate and help women together. I haven't asked them to go out and sponsor us and pay them to do that. I haven't asked them to do that yet. I might not. It's each one of them is a different relationship. It's hard for me to explain. I just.
Or even like, not even just talking about the Oprahs of the world, right? That's like the top of the top in terms of influential, but just talking about any influential person that wants to be in conversation about this. They obviously care to spread the message and they care about the problem that you're solving for.
Yeah, we have had people help us that do podcasts that are women's advocates. They do podcasts for women, and they've been very helpful. And they do drive traffic to our site because they want to help. They realize this is an opportunity, a solution that women don't know about, and they want to help women. That's their mission, is to help women. So we haven't paid them to do it. They've done it, and we really appreciate it. But that's part of their mission, is to help other women. And so we have had I've done several podcasts with them, and I'm going to do more. And the PR agency's been critical in identifying them because I don't know them. I'm just here at UCLA, and I had these stars asking me to talk to them about their health, and then they get excited. So I don't know PR, but we have an agency that does, and they've been great to identify influencers and people who do podcasts to help us.
And then Rhonda, in terms of your time spent, I'm just thinking about all the things that you have on your plate, right? That you're a teacher at UCLA, you're doing the research, the academic research as well. You have this company now. How do you think about dividing your time? Because I think there's a lot of founders out there that They're maybe the creative, maybe they are the chief medical officer. They are everything but the CEO, right? And that's totally okay, by the way. I'm a big endorser of not being the CEO if that is not where you want to spend your time or the role that you want to do. Can you talk a little bit about how you divide your time? Like, how do you fit all of this in? Because
Yeah,
it's a lot.
it is a lot. I'm at a really good spot at UCLA right now because I have it's a state FTE position that gives me support. I have an endowed chair that gives me support. The NIH grant I have for 7.2 million is for 8 years, and so I used to put in grants to like every 2 or 3 times a year, and it was a lot of work. And now I don't really have to. I have a lot of support because I've worked so long, and I have endowments, and I have things and the NIH grant was huge to free my time up. And when it freed my time up, I said, what do I want to do? And I just thought it was just so important not to just be I've been an academic forever with papers and grants, papers and grants, papers and grants. And I see patients in the clinic. And when I see patients in the clinic, I'm like, it's more than papers and grants. We've got to we've got to take a treatment to them.
Yeah.
I want something more on my tombstone than, papers and grants. I want it to be that I actually did something. I brought something to the world that helped somebody. Nobody's going to remember my name. That's fine. But I want to know that I did something that was more than just papers and grants, giving presentations, and it's an ego thing. I don't care. I mean, I want to do something. I want to leave something behind. And when you see Alzheimer's is a huge problem. It's taking over the healthcare industry. If you've ever been to nursing homes, every memory ward is full of a bunch of women, and it's sad. It's mothers, it's sisters, it's everywhere. Alzheimer's is huge, and it's 2/3 women, and it's not just because they live longer. So the elephant in the room, obviously, is that do women who have cognitive issues of menopause, does that or does that not have anything to do with Alzheimer's? That's the question, right? And I don't know the answer to that, but it's scary to think about. And the way I see it as a neuroscientist is this way, and I explain it to my patients. Alzheimer's is 2/3 to 3/4 women, still 2/3, even if you correct for living longer. It's still 2/3 women. There's got to be a reason. The question is, could that be due to loss of neuroprotective estrogen when they're 50? That's the question, okay? So now, how do we get there? Well, we know that Alzheimer's is mostly women, and we know that that's too late for treatments. It just is. If you've seen treatments, Alzheimer's and what they do, they don't do much, okay? And they're trying to get better, but the way they're trying to get better is they're going to earlier time periods. So instead of Alzheimer's, they're going to mild cognitive impairment. That's the 10 years prior to Alzheimer's disease, where they have just a little bit off, not much, just a little bit of hint of things, regions of the brain, maybe a little PET scan, maybe a little, not much. They're still functional, right? But it's 10 years prior to Alzheimer's disease. All the big pharma's in there trying to develop drugs for Alzheimer's disease there. And that's right. That's where they should be, because prevention is worth a pound of cure. You can't reverse some of that stuff when it's too late. That's just a fact. So everybody's going with mild cognitive impairment. Well, what's earlier than that? It's women with cognitive issues of menopause, and they don't meet criteria for deficits yet, but they know they're worse on certain things. And it also affects the hippocampus, which is the area where Alzheimer's starts, with functional changes on the MRI. So a lot of things contribute to Alzheimer's, but could it be that the reason women get it more is because they lose estrogen and then they're afraid to take any kind of HRT? We won't know the answer to the question. This is interesting to me, really interesting. This is kind of like my life's goal at this point. I'm just saying. So how will we know the answer? So right now there's a very big study going on in the UK. We don't ask, well, are they demented? Well, they're not demented. We know they're not demented. They're normal, but they know that they're not at the same they were 10 years ago, okay? With their verbal memory, with their click, 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 click. We know they know they're not the same. Cognitive testing will show they don't have a deficit, but it's not like the other things are. They're a little bit off on a few things, right? So it's being done well now. Finally, there's a big study in the UK where they're looking to see if women who have cognitive issues do or don't develop mild cognitive impairment Alzheimer's later. Now, I'll tell you right now that even when they do that study, we won't know if it's causal until we have a treatment to go in and reverse brain fog and see if that causes a reduction later. So right now we're doing Cleopatra. As we're treating them, we know we can treat them in the short term and get these symptoms better. after they take it for 12 months, we can get them better. Will that or will that not decrease the incidence and severity of mild cognitive impairment in 10 years? I don't know. But I think it's better than doing nothing.
I agree. I absolutely agree. I'm actually going to go onto your platform after this, and I'd love to meet with people because I'm right in all of those sort of key zones that you're talking about. But this has been so helpful. I wanted to ask you if you have any parting wisdom in terms of the founder experience specifically, like starting your business and how it's been different, obviously, from the research and the academia piece of it. Do you have any foundational advice for founders as they are looking to grow and scale their businesses, of things that you've learned so far in this journey?
I think I'm going to take advantage just to be selfish and ask for your help. Instead of, I mean, I've said kind of my problems and what we did kind of before. I'm going to take this opportunity because you guys know things I don't know. And so if you guys can help us, we're doing the VC round. If you know people that are interested in funding women's health, if you can email me with some names, we need to find women who care about this. That's what we need to take this to the next level.
I have a lot for you. So I'll be in touch after.
Just email me.
After this.
We can start the process and just reach out and send them a pitch deck and just start to talk to them. That's what we need, because that's not my area, is how to do that. And that'd be very helpful. So thank you.
Amazing. Well, thank you, Doctor. We so appreciate it. We love what you're doing. Like, thank God you are looking for the solution so we can all be smarter for longer and thriving for a lot longer.
Yeah.
So really appreciate it. Thank you, everybody, for being here.
And thank you. Thank you so much for having me. I really appreciate it. And I think you're making a difference by, we're working on this together.
Awesome. Bye, everybody.
Bye-bye.